Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
With the help of a simulated patient, we would like to demonstrate treatment planning and instrumentation in oral surgery. The establishment of a treatment plan depends upon a diagnosis that must be firmly established before we begin anything in the way of surgical therapy, because surgery is final. There's no remaking or redoing what we carry out for this patient. Consequently, a great deal of time must be spent to make sure that the diagnosis upon which you base your treatment plan is one that is tenable and sound. Patients will come to oral surgery clinic with their records, as we have seen before. The records will include an extraction slip, a recommendation for the removal of teeth or other surgical procedures. But in this situation, this is a communications document. It relays one man's impression to another, and you must be sure that you do not follow this as a dictate, but only use it as a guide to the area that requires your diagnosis and your treatment plan for which you are responsible. There is an opportunity for misunderstanding in the relay of this information and request. There can be human errors in marking the wrong teeth. There can be other misunderstandings about overall treatment plans that deal with many of the variations in restoration and prosthetic dentistry. So one must be sure that this is used correctly, and whenever there is any question about the diagnosis or which tooth is to be removed, it is well for you to thoroughly go over your own findings and then call either the man who referred the patient and get any misunderstanding resolved without troubling the patient. Or if there is need for consultation from another clinical department within the school, make sure that you call a representative from that department so that that can be evaluated and you can approach without anything that's equivocal in the nature of the diagnosis. In the treatment planning, the radiographs for the given surgical procedure are of importance. The radiographs will give us details as to the morphology of the roots, the density of the adjacent bone, the proximity of regional vulnerable anatomy and pathology, will dictate the pathways through which teeth can be removed, and will therefore provide us with information for technical efficiency. For the premedication of the patient, we would start with possibilities of additional adjuncts to patient control. After all, it is the rapport that we establish with our patient that is essential. So informed consent, assurance on their part that they are aware of what is to be done for them, and then an area of confidence that you establish with them is most important. You must be able to control your patient before you can carry out any work for them. These aspects of control begin with a psychological establishment of rapport with your patient, and they may in certain instances require additional adjuncts to patient control.
The IV solution used in the oral surgery clinic consists of lactated ringers with 5% dextrose. The tubing is initially primed to eliminate any air bubbles in the system. The IV tray that we will have in each of the operatory will contain a tourniquet, an on-board, as well as the tape to fix the angiocat or the butterfly. We have sponges to cleanse the site of the venipuncture, and we will have the butterfly, 23 gauge butterfly, as well as a 22 gauge angiocat to perform the venipuncture. Whenever conscious sedation is utilized in the clinic, a pulse oximeter is absolutely necessary to monitor the oxygen saturation of the patient throughout the entire procedure. Another anxiety service that we have for the patients is that of an analgesia machine. Demonstrated here is a wall-mounted unit. This wall-mounted unit will consist of a nose piece, the tubing to deliver the gases, a rebreathing bag, as well as the monitors. This is a fail-safe system. Fail-safe in the sense, in the word that it will not operate without oxygen. The supply of oxygen and nitrous oxide is, for this machine, is delivered from a central point. Rooms without a wall mount unit can be supplied with a portable unit. The portable unit is the same unit as the wall mount. It will have a nose piece, the tubing, the rebreathing bag, as well as an oxygen nitrogen monitor. These units will have their own gases, the oxygen as well as the nitrous oxide, and these gauges demonstrated here demonstrate the amount of oxygen as well as nitrous oxide in the reserve in these tanks. These gauges must register above 0.
We will find, again, one who is prepared, we hope now psychologically, as well as physically, for what we hope to carry out. Anesthesia will be administered utilizing local anesthesia. We have, again, scrubbed so our gloved hands are clean, and we would be able to proceed with the administration of the local anesthetic. In the administration of local anesthesia and in the work that's carried out in surgery, it is well to segment the areas of procedure. For example, if we were going to work in the mandibular arch and in the maxillary arch on this patient, we obviously could not work in both of those areas simultaneously. And therefore, we would administer the local anesthesia to the mandibular arch and then carry out that work. And as we were completing that work, then we would proceed with the administration of the anesthesia in the maxillary arch, and then go back and finish the work in the lower. And then by the time we're ready to work in the maxillary arch, anesthesia is at its appropriate level. So it's not only for keeping the local anesthetic just ahead of your work for maximum effectiveness, but also the aspect of the volumes of local anesthesia that are administered. We don't want to administer a large volume of multiple injections all within a short space of time, because when we do this, we increase the potentials for toxic reactions to local anesthesia. The instruments for a specific procedure are built upon a basic set, and they should be thought of from the beginning of the first incision to the placement of the last suture.
The instruments required to complete the surgical procedures are listed in this chart that you are now observing. This chart will be posted on the wall above the instrument cabinet in each of the operatories. The instruments in the top compartment are individually wrapped because they have been sterilized. They will be removed from this cabinet with a sterile but clean surgical glove. The left bank of drawers will have a writing platform where you will find a surgical manual to assist in the clinic. There will be a blood pressure monitor. There will be extra sterile towels that can be utilized in the surgical procedure as necessary, and postoperative instructions transfer forceps is provided to transfer the sterile sponges to the bracket tray. It is also used to transfer the anesthetic solution, the needle, as well as the Q-tips. The surgical blades, as well as the sutures and the ascription, may be removed with a sterile but clean glove because these have been individually packeted. The transfer forceps is then repositioned in the container provided in the face of the cabinet.
The bracket tray should be arranged in an orderly fashion, and we will look at that for the moment. It will have the instruments arranged in the sequence that we plan to utilize them from the beginning of the procedure to the end.
The handpiece will be draped with a sterile sleeve. The blood products will be collected in a disposable container beneath the Mayer stand.
In working on the mandibular arch, we would like the patient so positioned that she is comfortable, that the head and cervical spinal column is generally in a comfortable position. When her mouth is open, the mandibular occlusal plane should be horizontal, parallel with the floor. Just open widely, if you will, please. Actually, in this instance, it is not quite horizontal. As you can see, she's a little too far back. And so we would elevate the chair slightly, bringing her up a little bit. And then she should be positioned also so that when this field, when her mouth is open, and we're working on this field, the level of the operating field should be so placed that your hand level is lower than your elbow. In that manner, you can work directly and you won't be at an awkward angle. So in the mandibular arch then, the patient's mouth open, the mandibular occlusal plane should be parallel to the floor. A little later on, we will demonstrate that in the maxillary arch, the occlusal plane of the maxillary teeth should be perpendicular to the floor, and the patient then will be tipped way back. Let us attempt to demonstrate here a few of the positions of the operator and the assistant as we go through the access to the several areas of the mouth. Our surgical assistant, Miss Itzel, will begin the lubrication of the commissures of the mouth. In surgery, often we retract the corners of the mouth and cheek rather excessively, and unless the mouth is well lubricated, the lips may crack, and so for the patient's comfort, we begin in this manner. We will attempt to show the several positions of patient, operator, and assistant as we go into the several areas of the oral cavity for surgical procedure. And Ms. Itzel has the suction here, and this will be helpful in clearing the field as we approach the area for access. We've had the patient positioned, so when she opens, the mandibular occlusal plane is horizontal and parallel with the floor. The exposure of the field comes by way of retraction of the cheek. Patients will tend to want to cooperate with you, and when you retract in the direction, in this instance, toward the patient's left, her natural tendency is to comply and to turn her head toward the direction of the traction. You should explain to your patient that this is not what you want them to do, but rather to turn slightly toward you and to retain that position even though we are pulling their cheek in that direction. This will keep your field exposed so that you're able to operate. After the anesthesia has been administered, we frequently will use a curette to test for soft tissue anesthesia, utilizing it in the free gingival margin area and applying it to test for the lack of any sensation. You can prepare the patient that they will feel some pressure and perhaps hear some noise as instruments are applied, but that they will not feel anything that is sharp. We intentionally avoid the terms of pain and hurt as we again are trying to retain elements of rapport in operating on the patient. You always prepare your patient for everything they'll experience. Do not surprise them as you proceed. And as you start to apply pressures, here we are using the 15 blade in the manner that is shown going into the gingival sulcus. And we would divide the epithelial attachments, keep the blade in contact with the tooth as we go into the embrasure. That would be followed by the use of the periosteal elevator, the small end of the periosteal elevator, and utilizing a rest finger on the teeth, we would then go into the base of the papilla, go down to alveolar crest of bone and reflect the flap out. If we then wish to mobilize teeth, we would use a dental elevator, and this 77R elevator is an appropriate one that then would go into the area of access from which the flap had been reflected so that we would not bruise any of the tissues. We never use this instrument unless the free gingival margin flap is retracted away, because the bone must be used as the fulcrum and not the gingival tissue. After we had obtained preliminary mobilization of the tooth in question, we would then apply the forceps. Forceps are designed so that the beaks of the forceps should be in the same long axis of the roots of the teeth. Consequently, the lower forceps has a more or less right angle position to the beaks as compared with the handles, whereas the maxillary forceps tends to have a more linear relationship between beaks and handles of the forceps. The forceps are grasped well down on the handles, and they are grasped in this manner so that you do not have anything that is awkward in the neuromuscular relationship of manipulation of the tooth. If you engage the handles in a backward or some awkward position of this nature, you will not have sufficient control over the manipulation of the tooth. Teeth tend to be resistant to mobilization, and as you start the mobilization, it requires a good deal of force. As the tooth begins to luxate, you use less and less force until, again, at the time the tooth is ready to deliver, it is just literally lifted out of the socket after you have it sufficiently mobilized. In the traction that's required to break down the periodontal membrane and expand the alveolus to lift the tooth from the socket, it's necessary to support the jaw so that the mandible is secure while the tooth is being mobilized from it. In that effort, then, one can use the opposite hand, placing the thumb on the occlusal surfaces of the teeth on the opposite side, a finger at the inferior border of the mandible, and then the beaks can be applied to the tooth in question. We're quite careful in the application of the beak, watching where it goes, so we don't engage gingival tissue. So we only engage the tooth. We'll slide the lingual beak down carefully and watch it go into the sulcus, and then we would close the forceps slightly and slide the beaks down on the buccal. Then we would support the mandible securely, inform the patient that they will feel a good deal of pressure for a moment, and then we would begin the luxation of the tooth with the forceps. In conical shaped roots, we can add to the buccolingual motion an element of torsion in any single-rooted tooth that tends to have a conical root configuration. Another method for the support of the mandible so that the patient can use their own muscles of mastication to support the jaw while we're using forces of elevators and forceps is the use of a rubber bite block, shown here. The patient is instructed of its use. They are shown the bite block. They're told that this is to be put in the other side of their mouth, and they're asked to close on it in order to support the jaw. So we'll do that at the moment. We'll secure it well, ask the patient to close, then we can expose the field again. And then as we're utilizing an elevator, say in the back part of the mouth, if we were going to place this elevator in this manner and rotate, we'd tell the patient to bite down firmly at that particular time when we're exerting force. When using an elevator that tends to have a sharp blade, another method to safeguard the patient against the potential abuse and accident of these instruments is to place your finger on the lingual aspect opposite where you will be placing this elevator force. Then in the event of an inadvertent slip up in this manner, it's obvious that you're going to stop instead of burying that instrument in the patient's soft tissues of tongue or floor of the mouth. These then are methods in which the mandible can be supported. In connection with the use of the rubber bite block, it's well to keep in mind that intermittently the patient can bite down and by using the elevators of the mandible firmly support the jaw so that you move the tooth and not the jaw. However, this position, if maintained for a protracted period of time, is uncomfortable. Muscles will go into spasm, so that intermittently the prop should be removed, the patient allowed to close, and whenever we ask the patient to close, we will always, if we have an operative field open, a socket that's open, a flap that's reflected back, we will always take a sponge and ask the patient to close down, if you will, while we are either changing our instruments, selecting a new instrument, or in any way involved in a delay from the actual work in that field. The position of the operator in general should be as forward and direct as possible. We utilize direct vision in all operative fields, and very rarely do we use any reflected image in oral surgery. In the mandible, there are some instances where in the anterior midline procedures, the position of the operator can be from the rear. In that instance, the patient is lowered, the operator gets behind the patient, the chair is tipped back slightly, so that when she then opens, the operator has, once again, the advantage of direct vision of this particular field and can manipulate, again, with forceps or other instruments quite readily from this posture. As the assistant retracts the cheek, it is well to keep in mind that the position of the head must be maintained and light must be established into the field, so that often the suction tip can be used to retract the lower lip downward to allow more light to gain access to the field while the mirror is being used to retract the cheek. We would reverse this situation on the right side. The retraction would be made in this manner. The patient would turn away from the operator. The assistant would reach around behind and take the mirror with her right hand. And in this manner, we could again work directly on this side. So we have demonstrated the access around the circumference of the mandibular arch, and now we'll turn our attention to the maxillary arch, and we will change the position of the patient so that we can obtain access to the maxillary field. The patient has been repositioned for the approach to the maxillary arch. We will note that she's been tipped way back so that when her mouth is open, the maxillary occlusal plane is perpendicular to the floor. Then with the operator positioned laterally, he's able to bend directly forward and have full direct vision of the maxillary field. In retracting the cheek for the maxillary field, one will remember that the buccinator muscle is put on the stretch when the mouth is opened. So if the patient is open to a maximum range, the cheek is tight and you cannot retract it well. So for retraction in the maxillary arch, we'll want the patient's jaws partially closed together. That will keep the buccinator somewhat relaxed, and we then can retract laterally. She'll take that, and we'll also be able to retract in this manner. And if the patient again is instructed to keep turned toward the operator and not to follow the force of the traction of the retractors of the cheek, then we'll keep the field in view. In the approach to this region, we could apply instruments in the same manner that we did in the mandibular arch. This a curette applied to the buccal and to the palatal gingival margins. We could apply all of the other instruments in the same manner we demonstrated in the mandibular arch. And in the case of forceps, we will note that the upper forceps has the beaks again in line in this number 150 forceps, in line with the handles. The handles are grasps with the handles well placed downward in the palm, and the beaks are slid around the neck of the tooth in this manner. Now, as we apply forces to the maxilla, it is our hope to control the position of the head so that when the forces are applied to the tooth is moved and the head is not moved. Therefore, if you will place your finger on the buccal surface and your thumb on the palatal surface, you'll be able to so engage the alveolar process that you can support it, and you'll have an index of how much pressure you are using as you attempt to luxate the tooth. The tooth is never pulled, or there is never any traction exerted until complete mobility has been obtained. As a matter of fact, when the first pressures are used, there is actually a force toward the apex rather than any traction exerted on the tooth. Once then mobilized, again the same sequence of muscle groups beginning with the forearm and winding up with the wrist, so that the final delivery of the tooth is a gentle one and not one that is sudden or violent. The approach to the opposite side is achieved in the same manner, asking the patient again to turn away from you. You maintain your direct vision and position. The approach is made with the retraction of the cheek with the mouth partially closed again, and we have an approach that is again feasible to the maxilla on the right side. So it is these positions that will allow us to gain access to the maxillary arch. In the palatal region, occasionally for impacted teeth and other pathology in the palate, hyperextension and maximum opening would be required. These then are the several approaches to the different quadrants of the oral cavity, and we mentioned when we were speaking about anesthesia that we would divide up the work. For example, if we were going to prepare a mouth with multiple extractions, we would confine the work to one side of the mouth at a time. This means that the patients would still have the opposite side of the mouth for mastication, and if there were problems with hemostasis, why the patient would be able to control postoperative bleeding episodes because only one side of their mouth would be involved. As we were demonstrating earlier, if for any reason you leave the field, you always place a sponge over the operative field, have the patient close on it. Throughout the procedure for the division of tissue, removal of bone and teeth, we would use suction to keep the field clear. However, in the closures, we would use intermittent pressure with sponges in order to avoid that. In the alveoplasty, we would use with the Rongier forceps that are used to contour that, and the filing of the bone done with a double-ended bone file as we are finally contouring the bone beneath the flaps. Then the soft tissue flaps are trimmed so that there are no excesses and pathology is removed, trimmed with scissors, and then the sutures are placed. The sutures applied in a manner in which you've been previously instructed, utilizing 3/0 silk on this particular suture needle. The needle is grasped just with the tips of the needle holder, and that gives control to the needle point as it penetrates the tissue in this curved cutting needle. When the final sutures have been placed, and incidentally, before you close, before you insert any sutures, an instructor's check is required. This is necessary to make sure that the contouring of the ridge is satisfactory. So when that has been attained, you'll proceed with the closure and the insertion of the last sutures. The pack is placed over the operative field, a moistened pack so that it does not adhere to the mucous membranes. Throughout the procedure, the bracket tray should be maintained in as orderly sequence as possible. It is this neatness and arranging of instruments that is a part of the assistant's role.
Following the procedure, the patient notes will document the diagnosis, the anesthesia, the procedure, complication, if any, postoperative instructions, any medication prescribed to the patient, the disposition of the patient on discharge, and revisit as needed. This must require a signature of the instructor and will be dated. All patients leaving the oral surgery clinic will have in their possession a postoperative instruction sheet. This instruction sheet must be reinforced orally by the students. A suggested dietary menu is also provided with this instruction sheet. And extra sponges to assist in hemostasis is also provided. The departmental code, as well as the surgical procedure code, are posted on the walls of the clinic. Each patient will present to the oral surgery clinic with a billing sheet. The billing sheet would include C for completion. The procedure code will be prefixed with a U to designate an undergraduate student. It also lists the tooth number and the appropriate fee. The student must provide his provider letters. This sheet must have the signature of the instructor assigned to the case.
With this, we hope we have oriented you as to the approach to the patient for the treatment planning and the application of instruments in the oral surgery clinic.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.